So often when I present on ABO fetal maternal incompatibility or on ABO blood group, right, I get asked the question, does how does my blood group, like ABO blood group, affect my diet? How does it affect who I can marry? If I'm blood group O, can I marry someone who is blood group A? If I'm blood group, should I eat this food or that food, right? Today I'm not going to be talking about food, but hopefully at the end of my presentation, I hope to shed a bit more light on how ABO blood groups can affect, the association that it has in terms of marriages, specifically the children that are born out of these marriages, right? So this is true because, if the mother and the baby are ABO incompatible, kindly excuse me, let me do a few. All right, thank you very much. So sorry for the interruption. So basically today I'll be talking about evaluation of the clinical occurrence and predictive marker for ABO hemolytic disease of the newborn, right? So what is ABO hemolytic disease of the newborn, right? It's a clinical condition in which the red blood cells of the fetus or the neonate is destroyed by antibodies that are from the maternal system. Now, normally, our bodies do not produce antibodies that are complementary to our own antigens, right? But in the unique situation of pregnancy, you can have, you have the mother and the baby occupying the same body. So it's possible for the baby to have a blood group system that is quite different from that of the mother. And as such, the mother could have antibodies that could actually pass through the placental barrier and then affect the baby, tagging the baby's red blood cells for destruction. Right now, we have two types of these antibodies, right? We have the IgM, the IgG subclass in the blood group systems, right? But the IgM, the nature of the IgM is so large that it cannot actually pass through the placental barrier. However, the IgG is so small that it can permeate, the cell junctions of the placental barrier, bind to the fetal red blood cells, and initiate destruction. Now, this destruction of the red blood cells can lead to fetal anemia, and if the destruction is quite severe, it can lead to neonatal jaundice. That's accumulation of bilirubin in the eyes. That's what we see as, the yellowing of the eyes and the skin and all that, right? Now, if the jaundice, if the destruction of the red blood cells is quite severe, okay, it can actually lead to the bloating of the baby. This is what we call the hydros fetalis, right? You can see an example of that situation here. So this can actually lead to the birth of the baby in utero. Okay, good. Now, the most severe form of hemolytic disease of the newborn is caused by the resource system, right? The antibody to the resource D antigen. However, as it stands now, we have a solution to that. There's Rogam, which is prescribed to mothers who are susceptible to this to actually prevent the hemolysis from occurring. But however, we do not have a therapeutic agent for the hemolytic disease of the newborn that is caused by ABO incompatibility, right? And why is this so concerning? Why is this so concerning? Now, unlike the RH system, right, the ABO antibodies that can actually cause this hemolysis, they are naturally occurring. That means that we already have them. You do not need to be transfused, or the mother does not need to, give birth first before the baby becomes susceptible. The baby is susceptible even in the first pregnancy. That's one thing. Now, another thing is that for blood group O, right, you have both A and B antibodies. Now, these antibodies, it has been determined that these antibodies, a major proportion of it is actually the IgG subclass, which are the small ones that can actually permeate the placental barrier and cause the destruction of the red blood cells. Now, we haven't done a lot of studies with respect to ABO, hemolytic disease of the newborn. looking at the AU, then it should be which is quite interesting because we all assume that once you are blood group O, you have A and B antibodies, but we've never really looked at how much of it do you have, what are the levels, right? And it's quite interesting that some people have very little amount of it, some people have quite a high amount of it. And from the antibody score that I did, it shows that the prevalence, in fact, the IgG component of it is much higher than the IgM. So it was quite interesting. What is accounting for these changes, right? Why are people developing more IgG antibodies as compared to others, right? Thank you very much.
Thank you. Thank you very much, Mr. Sama. It's time for questions. So please, any question? Any question, please? Any question? Okay.
Thank you very much for the wonderful presentation. In your introduction, you said that you were going to talk about marriage, how the HDM talk about. But in your presentation, I didn't hear anything of the paternal influence of the HDM.
Thank you very much. So that was actually part of my conclusion, right? So, of course, if the mother is blood group O, then if the baby's incompatibility, whether the baby is A or B, would depend on the blood group of the father, right? But however, ABO status does not preclude you from marrying someone, right? It's just that when you are blood group O, or when your resource status is negative, then there are certain precautions that you have to take during childbirth, right? So if you are blood group A or blood group B, it does not prevent you from marrying someone with a different blood group. Thank you very much.
Any other question, please? Yeah, please come for it. This is a nice topic, and I expect a lot of people to come out with a lot of questions. Yeah, because it's something that a lot of people would like to know before they get married.
Thank you for this opportunity. I realized that during your presentation, you did mention you recruited them during their third trimester. So why third trimester, to be specific? And also, people only get it, per my knowledge, I know that they get it after their first pregnancy or miscarriage, but I did mention that they can also get it even during their first pregnancy. And after they gave birth to, you did mention most of the mothers, they didn't send their case to the hospital to be treated. I know that neonatal jaundice, and when you expose them to the sunlight, it can degrade it. It can degrade the bilirubin. So if they have the hydrophytalis, how can you also deal with that too? Thank you.
That was quite a mouthful. All right. Interesting. Let me start from. Hello, my brother. Could you please come back? Yeah, I may need you to remind me of some of the things that you said. Yeah. So with regards to the hydrops fetalis, I will start from the last bit, right? So the hydrops fetalis usually occurs in vitro. Sorry, in vivo, right? Sorry, in utero, right? So the baby, develops edema, in the womb, right? So by the time the mother gives birth, the baby is dead, right? That's hydrops fetalis. So it has not really, has to do with the neonatal condition, right? Can you remind me of the other question?
Thank you. So I did mention that you said you recruited them during their third trimester. So why third trimester, to be specific?
Yes. So thank you very much. As you have realized in your research journey, the research is quite difficult, right? So my study was a longitudinal study, right? And then so I have to take the blood sample of the mothers and then follow up with the neonatal distance. So if you take it earlier than that, right, there's a chance that you will not get the antibody titers that are relevant to, the neonatal period or the patrician period. You understand? So you take it as close to birth as possible, so that you know that the antibody titers that you get in the mother are relevant to the position of ABO-HDN in the neonate. You understand? Of course, part of my recommendation was that we could do a much longer longitudinal study where we track the mothers throughout the period, first trimester, second trimester. But of course, the more follow-ups you intend to do, the higher the chance of what? Loss to follow-ups. You understand? So you have to recruit a much larger sample. Those were some of the factors that went into the decision.
Any other question? Any other question? Yes, please, come forward.
So I wanted to ask if some mothers take anti-D, some mothers, they get to know about it early and take anti, but so I encountered this. So did you take into account those mothers as well?
Yes, that reminds me of a question that he also asked, but let me address you. So, the anti-D, which is Rogam, right, is used to resolve the cases associated with Rhesus D. So that's quite different from the one that I presented. Though they are both hemolytic disease of the newborn, one is caused by Rhesus, one is caused by ABO, right? So with the Rhesus, the Rogam, what it does is that it actually, right after birth, the doctors administer it to actually mop up any cells of the baby that had gotten into the mother's system, so that the mother does not produce the antibodies, right? So of course, it will be good for us to do some research to check, okay, to see if, even after the clearing, were there still some red cells left to actually stimulate the mother. So if the mother does develop the condition in the subsequent pregnancy with Rhesus, then it's likely not all of the antigens were cleared with the Rogam, right? So I think there are some interesting studies that are looking at that, and it will be good to do some further studies on it. And then to your question, so you said mothers are only susceptible after transfusion or after the first pregnancy. So that is with respect to RH, right? With RH, you need sensitization in the previous pregnancy before it can happen. But with ABO, because you already have the antibodies, it can happen in the first pregnancy, right? Thank you.
Any other question? Any other question? If there's no question, give a clap of friend. I think we are having a good time listening to very good speakers. And the next speaker is, I don't know whether the person is here, Charity. Charity. If she's not around, we go to Cordier. Cordier. Oh, great. Okay. All right. You introduce yourself, where you're coming from, and then you tell us the topic. All right.
Okay, so my name is Amokwame Kodie, and I'm a teaching assistant. And today I'll be presenting on the topic and I'll be presenting on the topic multi-criteria GIS and AHP-based analysis for sustainable landfill siting in Sunyani Municipal. So I'll start from the introduction and through to the conclusion. So Sunyani was once the cleanest city in Ghana, but due to some challenges in managing our waste, such as urbanization and population growth, it's no longer regarded as the cleanest city. And also landfill is a common method for waste disposal, but if there are poorly located, they can cause serious environmental and public health problems. So the problem statement is that Sunyani Municipal is finding a lot of challenges in managing its waste, and therefore my work seeks to address it by using GIS to locate suitable areas to construct landfills. So the main objective is integrating GIS and AHP for landfill site selection. And our specific objective first, we create thematic maps for all the criterias and therefore do classification for it. Also to perform an analytical hierarchy process analysis to generate weights for the various criterias. And the last one is to perform weighted overlay to merge all the maps to produce a suitability map. So this is my study area, which is Sunyani Municipal. So first, the criteria we use are 9, and the first one is DEM, which is the digital elevation model, geology data, land use, land cover data, population data, soil data, rainfall, and then distance to roads and distance to rivers map. So we use this data to generate all the maps. And then after generating all the maps, we did what we call reclassification. So for the reclassification, we created 5 classes, and one is unsuitable to 5, which is highly suitable. So for the reclassification, if you take map like population density map, we don't want our landfill to be located closer to places that are densely populated. So we assign value of 1 to 8, which means the place is unsuitable to locate landfills. So that's how the reclassification is. So we did reclassification for all of them. And after the reclassification, we came to our AHP, which is the analytical hierarchy process to generate our weight. So for the AHP, it's a multi-criteria decision tool, which basically compares all the criteria and check which one to place maybe more important than the other. So it has a numeric value from 1 to 9, and 1 is equal importance to 9, which is extremely more importance. So after using the AHP, you have to get a certain value, which is called consistency ratio. And it's not supposed to be greater than 10% or 0.1. So after doing our AHP, we had a consistency ratio of 0.03875, no, 0.026, which is consistent, and therefore we proceeded with the analysis. So we did weighted overlay, and for that, we used the generated weights in percentages for the various maps in our ARC map to merge all of them to get our suitability map. So these are the results for the various maps. And this is our final map. So the red areas indicate unsuitable areas, and the orange are less suitable areas. Our light yellow, which is moderate, light green, suitable areas, and our deep green is the suitable areas. So the study is classified into 5, and very suitable areas were 290 hectares. No, very suitable was 290 hectares, suitable to be 10,659 hectares, moderately suitable to be 26,027 hectares, less desirable to be 10,349.29 hectares, and unsuitable areas were 2,694. So the recommendation I made after the work is that I use online data for this work, and therefore I recommend that if anyone is doing this work, the person should use a ground truth data or visit the field to get data and compare with the online data. And also, if maybe there are existing landfill sites that are now closer to residents due to urbanization, they should take action on that. Maybe a buffer can be created, or some action can be created to reduce the stench from the residents. Thank you.
Thank you very much. Any question? Yes, please. Yes,
So thank you for the presentation. Maybe whilst you were presenting, I missed it, but with the classification of your results as to where is a recommended area for you to be a landfill, what forms the criteria for that?
So I made mention, I use population as an example. No one wants to be closer to a landfill. So when we are doing the classification, we have 1 to 5 ranks. 1, which means unsuitable, and then 5 is highly suitable. So if we check, this is the population density map. This is the population density map, and the red areas are highly populated areas. So when we are doing the classification, we locate that areas with 1, which is unsuitable. Do you understand? And the blue areas to be maybe 5, which is highly suitable. So we do the classification for all the criteria, and therefore we proceed with our overlay. No, the criteria are 9: land use, land cover, slope. Okay.
Thank you. Any other question? Any other question, please? All right, if there's no question, let's really give a clap off into the speaker. Thank you. All right, the next speaker is Thewa. Please, Thewa. Please give us your name, or tell us your name, and then where you're coming from and the topic, right? Good.
Okay, so good afternoon, ladies and gentlemen. I stand on all existing protocols. I'm in the person of Thelma S. Namatipo from the Department of Epidemiology and Biostatistics from the University of Health and Allied Sciences. And I'm here to present a study with the topic Knowledge and Involvement in Tuberculosis Control Among Primary Healthcare Providers in the Adaklu District of Ghana. It's a study that is actually still going on, so I'll take you through it. All right. So this is my presentation outline. I'm going to take it from the introduction way through to the references. All right, so introduction. Tuberculosis is a major public health problem globally, which I'm sure that we are much aware of. And then we have figures to actually prove this. I'm not just saying it's a problem, it's actually a problem. So WHO estimated 10.8 million new cases of TB. And then out of those ones, there was 1.2 million TB deaths in 2023, of which Ghana is also included in this. Ghana recorded over 20,000 TB cases in 2024, but there was a treatment success reaching 90.6% from the previous figure of 87%. We may say this is an improvement, but actually it's not so good because despite this success, out of 44,000 cases, there was an estimated success of 24,000, but due to financial problems, the problems we can see from the figures that is still there. All right, so moving on. Our study is focusing on primary healthcare providers in the Adaklu district. Why primary healthcare providers? We know that primary healthcare providers are at the front line when it comes to delivering healthcare, equity and effective healthcare for that matter. That is why it is essential that we involve them in TB control efforts. And for TB control efforts to be targeted and effective, the primary health care providers, since they provide the first line of care, they also are involved in the diagnosis treatment. So if there's a gap or there's a case where they do not follow the guidelines, it becomes very problematic. That takes us through the problem statements and then the rationale. So despite programs or efforts such as the National TB Control Program, there's still a gap when it comes to health workers' knowledge and infection control practices. And if these problems are not taken care of, it would adversely affect diagnosis, treatment, and most importantly and most alarming, it would cause an increase in the transmission rates, which we don't want at all. So our rationale. Understanding healthcare providers' knowledge and involvement is crucial for improving TB control strategies. This is because when we understand the knowledge they have, we are able to assess if they are ready and capable enough to cater or fight when there's an increase on an outbreak of tuberculosis in our country. All right, so moving on to my objectives. My main objectives for our study was to examine primary healthcare providers' knowledge and involvement in TB control in the Adaku district of Ghana. And specifically, we aim at assessing the level of knowledge of TB control among the primary healthcare providers. And we also want to evaluate their involvement activities in the program. We want to see how actively they are involved. All right, moving straight to the methodology. Our study area is the Adaklu district, as I have stated earlier in my topic, and it is one of the 18 districts in the Volta region of Ghana. You may be wondering why Adaklu. Adaklu because it is a rural area, and then during the investigation process, we talked to the director of the health directorate over there, and he made us aware that TB is a problem over there. So we're like, sure, if it's a problem, why not study and tackle it? So our study design and method. We are using a cross-sectional survey design using quantitative data collected using quantitative analytical methods. And then we are using a sampling method which is known as the proportionate stratified random sampling method to select our primary healthcare providers since they are our targets. And then from data, we've collected that the population of healthcare providers over there is 62. And our sample size, we are going to calculate using the Yamen formula. We want 54 out of those 62 participants. All right. So continuing with our methodology, we are going to, for the data collection, we are currently using a self-administered questionnaire among the primary healthcare providers. And then analysis will be done quantitatively using data version 7.0. Our inclusion and exclusion criteria. The study would involve primary healthcare providers that are available at the time of study, and then we would exclude those that are on leave or are probably ill, or most importantly, those that do not consent to take part in the study. All right, so since it's a study that is still going on, we are focusing on the key points and implications. That is understanding primary healthcare providers' knowledge and involvement, since it is very critical in strengthening TB control efforts. We need them, so we have to understand what they know about it, so that if it's not enough, we improve it. And we also want to identify knowledge gaps. Their knowledge is very vital. If their knowledge is low, diagnosis, treatment, and even prevention will be affected, and we do not want that. Another key point is enhancing public health care providers' capacity, which would improve early detection and treatment initiation, thus reducing TB infection. And also, we would want to investigate strengthening public health care providers' involvement supports in national TB control programs. All right, so from our study that is still ongoing, we would say that tuberculosis is a major problem, and we'd want to involve our primary health care providers to solve this menace. So my acknowledgement is to the study participants who availed themselves, and then the organizers of this conference for accepting our abstract. Thank you. Please, I'm open for any questions and suggestions.
Thank you very much. Mr. Are you a graduate student? Undergraduate? I can see from the way you are presenting the steps. Very good. Right. Any question? Yep. Any question? Yeah. Please, any question? Okay, you can come for it. Huh? Okay.
All right, a very good presentation. Permit me to seek for a few clarification. The essence of this conference is to share knowledge and learn amongst ourselves. So we learn every day. You said you used a cross-sectional study, right? What is a cross-sectional study? That is my first question. And then my point number two, I'm looking at the take-home from your work. You know, TB is a very terrible infectious disease. And speaking of Adaklo, I've had opportunity also for working there before in a research collaboration that I was involved with UHAS. Now I want to find out from you, what will be the take-home message from your study once you are done? Assuming you happen to meet Kwabena Minta Kando, Honorable, the current health minister, and he says, Thelma, I have only 1 minute. How can you convince me your work is relevant? I think that'll be all. Thank you.
Thank you, Prof. Yeah. Do you get his question? Good.
Okay, please, thank you very much for the question. So to answer the first question on what a cross-sectional study design is, I would say that a cross-sectional study design is a study design that is used to collect data at a particular point in time. We, the undergrads, usually use this because of how we are time-bound to actually produce our projects with. So it's a study design that we use when we want to gather data at just a specific point in time. Thank you. Yeah, please. And the second question on a take-home message to convince you of the relevance of our study. Please, is that it? Oh. Okay, so if I have 1 minute, I'll just tell him that TB, as I have stated earlier, is a big problem, a very big problem for that matter. It's infectious. So it's in 2023, it's even surpassed COVID, which we all know that was a big problem. So if it was able to surpass COVID, that should tell us the magnitude of the problem. So with such a problem, I would say that we need the workers that are actually helping to solve the problem to actually be ready to solve the problem when it comes. So with this study, we would actually assess if they are ready. Are they ready that in case there's an outbreak or an epidemic, they would cater for it? So to convince him, I would say that we would need all the help and the resources to equip our frontline workers, which are the primary healthcare providers, so that they'll be readily available at any point in time to solve the problem at hand. Thank you.
Thank you very much. Mr. Okay, please. Your question.
Okay. Thank you for the nice presentation you have made today. Okay, my question is, you say you use proportionate stratified sampling method, right? And from the method you made mention that those whom you recruited, the nurses who are not on duty at the moment, you excluded them. So it means, per my observation, this is more like convenience sampling instead of a stratify, because stratify, it's like you are picking from a larger population and you group them based on age, like either sex or age. Then out of them, you randomly pick your sample from that population. But for how you go about your work, to me, it seems like a convenience sampling, not like you are, yeah. So if you can maybe explain how your sampling method is, like you can elaborate on it, I think it would be better for us. Okay, thank you.
Okay, thank you. So let me clarify it. We use that method and then we combined it with random, because per our studies, you can't just use stratified without actually adding another form. What we did was we grouped you see, at the Adaklu, there are 18 facilities. They do not have so much in facilities. But what we did was we grouped them into 3, the facilities that are available. They do not even have a working like hospital. What they have is the health center, the chips, and then 1 clinic. So what we did was that was our first stratification, by the way. And then from that, we got the number of workers at each of the facilities, where we got the total sample size of 62. That is the number of workers there. So let's say I go to the health center after we group them. We have 7 of the health centers. I take and I want a sample size of 54. So I take the 54, I divide it by the total population, and then I multiply by the people that are available in that facility. Let's say the 7. Then I get the number of people that I want from there. So after doing that, maybe I'll get a sample of 5. And probably when I get there, as you said, sample will be on leave. So we are not doing everybody there. So if you have 7 and I want 5, definitely I'm accounting for the fact that somebody will not be there. Please, I don't know if you are getting me. So stratify plus random. Yeah. Yes, please. But not all of them too. But please, thank you. I'll work on it.
Are you convinced by what he's saying? You get it? That's great. So you've gotten additional knowledge. That's great. Very good. So, Charity, is she around or she's yet to come? Okay, thanks. Yeah, thank you very much, Mr. Wa. That's very nice. It's a nice talk. The next person is Bala Madi. Bala Madi. Please, is he or she around? Bala Madi. Okay. I think this will suffice for the day, especially for this time or this session. And so we are done for this particular session. And if there's any other announcement, please do let us know. Or, yep. Okay. Okay. All right. You have something? Okay. Our gentleman wants to ask a question.
All right, so in your study, you mentioned that you wanted to assess knowledge and also knowledge levels. So I want to ask, are they the same? And then in your analysis, how will you measure those 2 variables? You said you measure knowledge and knowledge levels. So in your analysis, how will you do that measurement? Again, your study sites, you try to justify why you chose Adaklu as your study sites, and you said you went to the directorate. So aside that, did you look at other studies that pinpointed that place as a hotspot or something like that? That could, okay. And then I'm sure others have done something like this or a similar study like this. So I just want to know what will make yours unique and different from what others have done.
Okay, so to answer the first question on the how to access the knowledge. Okay, so to access the knowledge, we actually came up with a number of questions from our questionnaire, and then we are using a knowledge score. So as a healthcare worker, when we ask you various questions, we want to believe that you know them, and then we score it. And we were doing it on 70%. So when we are done, and then we calculate the knowledge score, and you have less than 70%, that means your knowledge is not so good. And then when it's more than that, we can say that you have good knowledge. Okay, so that's to answer that question. And then the second question on the relevance of the study sites. Please, is that it? Okay. So I said earlier that we went to the director. But before even going there, we did our own search and realized that it's actually a problem. but we want to be sure from real-time data. That is why we even went there. So yes, we actually did check if it was a problem. And you're asking that there are other studies on it. What makes ours different? What makes ours different is that there are works on it, yes, definitely. But the question is, are they up to date? Are they depicting what is actually on the ground today? So what we are aiming to achieve is to collect data real time, what is going, what is fresh. These people have been working for long. Are they still, is their knowledge good up to this point that they can chest anything that comes up when there's a problem? Thank you.
Please, are you okay with the answers? Are you okay? Oh, great. Any other question? Okay, thanks so much for coming for this session, and we hope that in the next session you'll be around again for us to appreciate your contributions. Thank you very much. So it's time for lunch. Please feel free, move around and then get to the place where lunch is served. Thank you. Have a good day. Bye.